Hi, my name is Louis Martinelli. I'm a specialist physiotherapist at Rehabilitation, and today I'm going to talk about the terms dose and intensity of therapy within neurorehabilitation. I have worked in neurorehab for 13 years now, and it's just over half of those specifically with exoskeleton technology. So hopefully I have quite a bit of experience working with technology, but in particular technology that can provide quite a high demand and intensity of training associated with neuroplastic changes. So here is the title of this talk today, and in particular highlighting just at the end, is there a link between these terms and therefore the demand that we now find in our settings with neurological technology. Here's the plan for today's talk. So I will go over the terms, dose and then intensity. What do we mean by them? Then relate this to neuroplasticity. I'll discuss the current rehabilitation guidelines and then whether we're able to meet these guidelines currently. And then the main section really is on what the literature says. We'll be looking at some studies in recent years highlighting, I guess, the pros and cons of certain studies and whether dose intensity are important factors within the rehabilitation setting. And then finally, I will talk on whether some of the neurotechnology that seems to be in demand at the moment in our settings can help provide the appropriate dose and intensity for our patients. Okay, so why is dose important? Well, dose, first of all, it's the quantity of therapy given. So, for example, if we're on an acute ward setting and we're able to see a patient, say post-stroke, for 30 minutes a day, 5 days a week, that's 150 minutes a week. We don't always look at rehab in this way, sort of quantifying it, but that would be the quantity or the dose of therapy that patient would be having. Okay, what is intensity and why is it important? Typically intensity is how hard a person is working. I'll come on to this a bit more specifically later on, but in this slide I've added some other words in as well to just describe how intensity is prescribed effectively. So for example, I think it's important to reflect on the importance of the frequency, duration and repetitions we have on the intensity of a specific exercise. But I'd say almost more importantly, intensity is very much linked to the effort that the person is putting in, but that is really combined with the difficulty of the task. So if we provide someone with a task that's too easy, they may lose interest and end up not providing enough effort, but quite the opposite, if the task is too difficult, a patient may lose interest really, really quickly and therefore not be able to provide the effort to create the appropriate intensity. Here's slide just going into more depth about the frequency, duration and repetitions from the previous stage, and actually one that we use very regularly in the exercise industry. Prior to physiotherapy, I had about 15 years in exercise prescription in the gym setting based on the sports science degree, and these terms are something that we use very, very regularly. So volume of training, if I'm in, and think of strength and conditioning in particular. If I'm thinking of the volume of training, what load am I lifting, how many repetitions and how many sets of those reps am I doing? Am I doing this twice a day? Am I doing it once or 3 times a week? So that's the frequency. But then in particular, intensity was often described. We would work out your percentage 1 rep max, that's the RM. We did this less, but we did this when we're doing trials. We look at a person's RPE, so the rate of perceived exertion, how hard someone's working. That can be like on a visual analog scale. And also a term that's been used a bit more recently, repetitions in reserve or reps in reserve. So I think this is very important for the neurological population actually, when you're looking to prescribe exercises and wanting them to work hard. Obviously at a high intensity your form can drop, and therefore we're actually wanting patients to provide a high intensity but not to the point where their form goes and they learn maladaptive behaviours. So actually RIR, the reps in reserve, is something that I think we do in the clinic a lot of the time. And you may have heard this phrase before, but prescribing exercise without considering the intensity is like a doctor prescribing medication without the dosage. here's the exercise, but how often should I be doing this? How much should I be doing this? Is often very key, but in certain settings very hard to implement. Okay, so we've just described dose, as in the volume, if you like, of an exercise, and the intensity. How do these relate to neuroplasticity? Which is a quick recap. Neuroplasticity is the foundation and driver to what we do when we learn, as we grow, and it's driven by behavioural, sensory and cognitive experiences. For example, finding a task that we're more interested in, that we're motivated by, that makes us feel a certain way, gives us certain physical feedback, as well as stimulating us cognitively, is where the neuroplasticity tends to happen faster. But to learn these changes, they need to be specific, intensive, with high reps, without being mundanely repetitive. I know we're talking about neuro here, but to my patients I sometimes speak more broadly. I think imagine at school when you're trying to be interested in something or trying to do a class, it was the teacher that was particularly interesting, that made history interesting, for example, that allowed you to remember the certain dates you had an interest in. If there was a class you were less interested in, it was very hard to make those neuroplastic changes to make that learning appropriate level. And remembering damage to the brain does affect how we learn and how the neuroplastic changes happen. What we see a lot of is obviously the brain will adapt to whatever happens, but these can often be maladaptive tendencies rather than adaptive. For example, if a patient's had a stroke and one side of their body is weaker and they have, say, like a difficulty lifting their foot, drop foot, for example, then you may find this patient naturally will circumduct the leg to still achieve the task, but we're doing it in a maladaptive technique rather than being able to work on the fine-tuning of hip flexion, knee flexion, dorsiflexion to provide a stride through. Their body will do, almost in a sense, do a shortcut and do the maladaptive response. If you haven't seen this article or summarising this article before, The Principles of Neuroplasticity by Klein and Jones is a very good read. It's very thorough and talks through the principles that we probably use from day to day anyway, to be honest, but in a really clear and matter-of-fact way. And again, this just highlights, I won't go through all of these right now, but this just highlights how dose and intensity of training or of therapy isn't necessarily a new thing. This article is over 15 years old, and these are out there, they're spoken about, and even more so now with technology being included in therapy, become almost more relevant. If you haven't come across these before, yes, use it or lose it is a failure to drive specific brain functions that can, that in the long term would lead to functional regression. Use it and improve it. So training that drives a specific brain function can lead to an enhanced mode of that function. Specificity. The nature of the training experience dictates the nature of the plasticity. So if I want to be particularly good at football, for example, I should be practicing football, not just other exercises that involve jumping, stepping in and kicking. Repetition. So induction of plasticity requires sufficient repetition. I think we know this from practice, and some of the articles I'll talk about later on definitely highlight this. Intensity matters. Again, on the previous slide where I was discussing how the effort and the difficulty of the task has to be appropriate to provide the right intensity. Some of the studies I'll talk about later on will try and quantify this. We have obviously time matters. And again, this topic salient. So the interest of the task has to be key for then the participant to improve in it. Transference. So this is, again, if I use a sporting example, practicing sort of cross-training can often benefit the end sport. So you break the individual movement down into its individual patterns and then work on those individual patterns to then put them back together to produce a better functional outcome. But sometimes it doesn't always work. We did a different exercise, for example, if someone had a lot of flexor pattern in their upper limb and they did an awful lot of flexing at home exercise program rather than sort of reaching extension, we might see an interference that person ends up losing or having difficulty with the extensive patterning, like a reaching task, because they've been quite dominant in a flexor task. And in my experience, there's nothing wrong with doing flexor patterning. It's just trying to do the correct volume. So you might do 2 extensor patterning movements combined to every 1 flexor patterning movement, so you have a balance there. So looking at the current guidelines for dose, for example, how much therapy should we be providing? The Royal Society of Physicians Guidelines for Stroke in 2016 outlined that 45 minutes of therapy a day enables people to meet their goals, and the easiest way of thinking this is in acute setting like a stroke unit, for example. So lots of the practices that I'll be involved in, again, we try and achieve this 45, can we do 45 minutes a day? And if we have a patient here at our clinic and we're looking for home exercise program, again, maybe striving towards what can you do at home, can we build up 45 minutes of therapy a day is a general guideline. Now this is the real key bit for me. Are we meeting these current guidelines? Now, there's the SNAP audit that was done in 2017 highlighted that we're not. We're actually averaging 25 minutes on the wards, if you like, of post-stroke intervention. So we're not meeting that 45-minute threshold, if you like. There was also a study I looked at a couple of years older than that suggested it was 30 minutes of therapy they were achieving. So I haven't been able to find a study that's obviously post-pandemic or during the pandemic, but I'm assuming the times might even be even more challenging than 25 to 30. And I appreciate there may be certain hospitals or certain centres that are able to provide more than this, but as a general theme, we're not able to provide enough minutes, hours a day to reach the 45 minutes. And if we think of the upper limb in particular, this is really quite striking, and you can absolutely understand it from a functional point of view of someone having a stroke and wanting to be on their feet. But in physio sessions, this is found to be about 4 minutes a day, and no T sessions, 11 minutes a day. So we're not getting, again, the appropriate therapy for that appropriate goal, getting the quantity up to the guidelines of 45. I'll mention reps in a few slides' time, but this also highlighted that, or Hayward, I should say, in 2015 highlighted the sessions with upper limb were achieving about 32 reps, which you can imagine if you're with someone for 5 or 10 minutes, repeated movements, repeated reaching, it's going to be hard to get much more into the tens and hundreds of movements. Now, Judy Bernard did many studies, one in particular looking at early mobilisation post-stroke, and just a quote that stuck with me was saying that patients are inactive and alone. I appreciate as therapists are often running from ward to ward, but sometimes the family members that we sat there with the patients realising there may not be too much stimulus, especially for exercise. But I definitely found out during the pandemic, working in community settings, the isolation that patients were having that was affecting their physical neuroplasticity and their potential, but also their ability to communicate and have a bit of drive as well. So there is two things here, I think. We're not quite meeting the guidelines of 45 minutes, but also how can we have an environment where patients are stimulated and motivated to then aim for these goals and these targets. Okay, so that's the intro done, if you like. What is dose? What is intensity? Are there guidelines? If so, are we meeting them? The next section now, we're going to look at the literature. So I've summarised about just over 10 studies here, highlighting what recent research there has been to see how important is dose and how important is intensity in the rehabilitation of neurological patients. The first study I've picked is Schneider 2016, and this was a systematic review, and I won't spend too much time on all of these studies, just to take snippets on, but please, do take a note and read them in more depth. Again, this highlighted that usual care was around 25 to 30 minutes, which would coincide with what we looked at earlier, but to see greater outcomes, their suggestions this needs to be 90 to 100 minutes per day to get these benefits. So this is also suggesting that the 45-minute guideline from the Royal Society for Physicians isn't necessarily the right threshold to get benefits post-stroke. So this is very challenging numbers to see. So if you think, well, we're doing about half an hour at the moment, we're trying to get 45 minutes, we almost have to, times by 3 what we're currently doing, and almost double as well what the guidelines may be for this study. But let's see what else is out there. Another study done at a similar time from McCabe was looking at robotics, FES, motor learning, in the upper limb post-stroke, and this was an RCT. They had a really high dosage in this. There was 5 hours of therapy a day, 5 days a week, and it was for 12 weeks. So you see a lot of hours in this one. And I think what I found particularly interesting is, yes, there were different interventions. There was motor learning, robotics, FES, and really positively, all groups changed in the FM, the Fugel-Meyer, an upper limb outcome measure often used in research. So this study, from what I took of it, suggested that yes, it's important that it was robotics or FES or motor learning. The most important thing was the dosage and the intensity. The fact that this was a high dose study that was 5 hours a day, 5 days a week for 12 weeks, that's what made the difference, because all groups improved despite what interventions they were having. So again, just logging that was 5 hours a day, quite a lot more than the 45 minutes that we're aiming for. Okay, the next study, really quite a well-read study, but also program, as you may have heard, the Queen Square program by Dr. Nick Ward. This paper in 2018 was looking at upper limb intensive rehab and chronic stroke patients. Again, if you look at a lot of patients, a lot of hours, so 90 hours over 3 weeks, I think that's about 6 hours a day. Again, Fugel-Meyer, upper limb outcome measure, an 8-point improvement at discharge. And what was really positive is that these changes were then continued 6 months post-intervention. So my understanding being that getting someone kick-started, if you like, with a high volume, high intense program, allowing them to then have access to greater movement, allows them to then go home, if you like, have their own home exercise program they continue to work at and progress at. So this high volume of training, physiotherapy, occupational therapy, this input early on, giving better long-term measures that stand the test of time in a sense. Okay, Chohan, 2012, so slightly older study. This was looking at the intensity of training on upper limb in strokes, and it was an RCT. So they had 3 groups of patients, people receiving 1 hour therapy a day, 2 hours of therapy, or 3 hours of therapy a day for 5 days over 6 weeks, not the same sort of dosage we've seen in previous studies. Again, positive though. Fugel-Meyer again was improving 6 weeks post-treatment. I guess in a way, no surprise. The largest improvements were in the people that were having more volume of training. It wasn't that people couldn't have or couldn't manage 3 hours of therapy a day, which you sometimes hear in our practice here. People saying, well, if you're providing 3 or 4 hours of therapy a day, how can patients tolerate that? It's quite the opposite. The more, obviously, integrated into a smooth program, but in this instance, the group that were having the 3 hours of therapy a day were having the best improvements. Okay, so more of a recent study by Tola, 2020. This was looking at high intensity rehab, again, a large number of patients, and they looked at people doing twice a day, 5 days a week, or once a day, 5 days a week, or a lower intensity care 5 days a week. And I guess we shouldn't be surprised really, but twice a day compared to once a day was better, and twice a day compared to low intensity standard care was better as well. And this wasn't just in upper limb fugal mara, if you like, patterns of movement. This was shown to improve their blood pressure and also their quality of life, which I think is a really important way to look at this as well. A variety of outcome measures can be appropriate, particularly looking at someone's well-being and seeing how they are improving post-sessions can be, as I'd argue, even more important sometimes, an improvement in the quality of movements in a fugal mara. Okay, so far I think we're saying that, or these studies are suggesting more volume of training, the better outcomes the patients seem to be getting. Another RCT. This one by Klamoff and Marcus State 2014 included robotic therapy, in a sense compared to conventional therapy. 8 weeks, so fairly long sessions, but just 45 minutes. The dosage wasn't particularly high. And I've included this one because although 45 minutes of therapy a day wouldn't be seen to be enough in the previous studies we've read, however, there was significantly greater movements in the robotic therapy group compared to the conventional therapy group, assuming such that the robotic therapy is having much higher levels of repetition, part of intensity, if you like. So two groups doing similar things, but just the higher reps appears to have really caused significant changes in these groups. Almost, you could say, surprisingly, considering it was just 45 minutes of extra therapy 3 times a week. Okay, just over halfway through, about 3 or 4 studies to go. I'm going to focus on the next few more on gait rehabilitation. And a Cochrane review in 2020, post-stroke, summarised that combining assisted gait training, electromechanical assisted gait training, with physiotherapy increased the odds of that participant becoming an independent walker. Wasn't perfect in the sense saying how much frequency or duration should be included, but mentioned that it's definitely important to know the time post-stroke appears to have different benefits for different patients. And they did highlight that we're not quite sure, in a sense, of the effective frequency and duration the training should have. So in a sense, I took from this, we know that it works. We've still got to fine-tune and decide at what time do we give it to patients and at what frequency and duration do we give it. Okay, Hortmead 2019. Again, I like the study because it's trying to combine a combination of dosage but also the intensity. How do we measure intensity? Are we looking at RPEs, for example? So again, an RCT post-stroke looked at almost 100 patients, split into 3 groups. We had high intensity stepping with difficulty stepping tasks, high intensity stepping with standard forward walking, and then compared to a low intensity stepping. 30 sessions over 2 months. And again, the high intensity stepping was shown to be greater improvements than the low intensity training. In particular, when you compare the high intensity stepping with difficult stepping tasks, which you could argue would cause the patients to be more concentrated in the task, maybe more motivated in the task compared to forward walking, the two groups, the group comparing the difficult stepping task with just forward walking should increase the confidence in their walking. So high intensity stepping was the best of all outcomes in a sense, but also combined with difficult stepping tasks that was going to challenge a patient, keep them involved, also improve their confidence with gait. Okay, last 3. Okay, so Winstein 2016. I picked these studies as well because this wasn't all studies that had positive outcomes, if you like. These are ones that were looking at intensity of training, doses of training, and seeing the effect they would have. So quite a high number of participants. This was 3 hours a week over 10 weeks. So compared to some of our previous studies, the first few that were having 5 or 6 hours a day excuse me, is a much lower dosage. And they sort of found at the end of the study there wasn't too much difference between this and the standard care. And to summarise, really, it was, hey, there may be something in this task-orientated practice. We know that task-oriented practice works, but maybe not 3 hours over the week. The dose is too low. We need to increase the dosage. Okay, this study was in the Physiotherapy Frontline magazine a couple of years ago, the Rathel study. Again, high number of participants. This was 3 sessions a week of 45 minutes compared to the usual care. And again, I think this highlights is similar to the previous study. Good study, potential to change. Just the amount of dose wasn't enough in a sense, especially compared to 5 or 6 hours a day. Compared to this is an extra hour and a half, 2 hours a week wasn't enough. And summarised, suggesting much larger doses are required. Okay, the final study that I found, again, Cochrane Review 2018. So this was again robotic upper limb training to improve activity of daily living, arm function post-stroke. Quite a number of trials in this one. The previous studies had smaller numbers. This was quite a high number of trials, 45 in there. And this highlighted that people who received robotic assisted arm training after stroke might improve the ADL's arm function and muscle strength. So, yeah, I guess no sort of firm confirmation there that this would work. And they highlighted that within their study there's a real big variation between the trial groups. Some are having high intensity, low intensity, small dose, high dose, and therefore we need to interpret this with caution. And I summarise from this that, well, reading the other studies, if we're doing something like this, then we need to get the dosage. Where 5 or 6 hours a day seems to be working, we need to try and push to those 3 to 4 to 5 hours a day to see whether we're then more likely to see positive outcomes post-treatment. However good the treatment may be, if we're not having enough dosage of it, then we may not see these improvements. Okay, so that's my quick snap at the literature. And the last couple of minutes, I'll just summarise what we've been through and hopefully relate now to why there is a demand for neurotechnology. So, to conclude, as some of the studies have shown, we haven't given enough time to look into the intervention to know what the appropriate dose and intensity should be. I think if you flick back to one of the earlier slides at strength conditioning, I think this is all pretty common sense. But if you look at athletes out there, they'll be doing their best to try and see how they can fit as much volume in as possible without being injured. So I think the science is there, neuroplasticity is there. The studies are now starting to show that we need this high volume of training. The challenge is how do we implement it if we're managing about 25 minutes a day when the studies are suggesting we need maybe 5 or 6 hours a day. Dose response is emerging from clinical trials. Generally higher dose, the better outcomes patients are having in the acute, subacute and chronic stroke. And yeah, somewhere between 15 and 25 hours a day shows that it's making the greatest changes. And really positively, a combination of different types of input, whether it's robotic, task-orientated practice, more conventional therapy, all seem very valid. It's really if we can provide those at dosage and intensity that meets the threshold. So the answer is probably in the question. So can neurotech help bridge this gap? So we now sort of know there's a gap. We're currently doing about 25 minutes a day. The guidelines are 45 minutes a day. But maybe we need to be looking at 3-4 hours plus a day. Can neurotech bridge this gap? I think from my experience in the last 10 years working at Pulse Rehabilitation, it's taken a bit of time for it to get in the consciousness of therapists, especially the last 7 years. It's really sort of exploded. Being approached by patients wanting to use technology, companies approaching us with their technology, saying it will provide better therapy for the patients. And what we've found is, again, it's the slogan, it's the right tech at the right time for the right patient. I don't think there's any quick fix with these things. But some of the new technology really does give us an opportunity to produce high reps, mass practice, high dose. From my experience using exoskeleton, gentlemen I just saw today can stand the step 3 or 4 steps with assisted 2 or 3. In the exoskeleton today, within 45 minutes, he's stepped just over 700 steps. Some of those facilitated, some of those where he's more active in. We're just getting that mass practice, and you can see his body learning the appropriate movement patterns is going to be a more appropriate method than 3 or 4 steps with max distance of 2, in my experience. The technology is very repeatable. Say for upper limb, for example, some of the modes there, you can repeat the same methods over and over and over again. Patients tend to like the technology. They, for example, they'll come in, maybe initially be assessed by a therapist. We can then set them up on a piece of kit after the session where they can then be getting extra benefits without that one-to-one therapy intervention. And as I said, it's to be worked alongside a therapist. There's no piece of tech here that's replaced the therapist just yet. The therapist needs to be on board with the tech. I think know the tech, practice it. Sometimes these things, like anything, if we haven't charged them up, can be unreliable. So it's our duty, in a sense, to know the tech well, provide a good service, but not be scared that it's going to take us over, in a sense. And I think the evidence is there. We get to see it in our practice quite regularly, how the benefits will be positive, but also looking at the studies that I highlighted earlier, I think most of them just saying, how do we build these numbers? How do we get things at 3 or 4 hours a day? That might be with therapist intervention, but if not, if I can set someone up on the FES bike for the morning, use the VR system in the afternoon, a bit of one-to-one therapy, in between that, a home stretching program, a home strengthening program, that can all add up to that sort of 3 or 4 hours a day by becoming almost functional, in a sense, not just 3 hours in one spot. So I feel, and that's my close here at Rehabilitation as well, that neurotechnology is absolutely part of bridging this gap, and to be honest, one of the only avenues I can see that will be able to bridge the gap from providing patients with expert therapy for that amount of time. I don't think we can expect these patients, say post-stroke, say limited arm and leg movements, to do this on their own. If they could do it on their own, I think they would do it on their own. They need support with these exercises, ideally with a therapist initially, and then being set up on a form of technology to get the main benefits. Thank you ever so much for listening. I hope you've enjoyed it and found it insightful. But at the same time, if there's any topics there that I mentioned that you didn't agree with or weren't sure on, please email me. I'm always interested to find out other people's opinions and points of view, and maybe lead future discussions on the area. So there's my email. Hopefully see you at the MIN conference in early March. And thanks again for listening. Bye-bye.